Welcome to the Explainer. Right, let's jump straight into this because we've got a lot of ground to cover. Today, we are entering a hyper-dense, really high-stakes clinical matrix, congenital immunodeficiencies. If you have ever felt totally lost in the massive alphabet soup of immune disorders, well, this Explainer is your definitive roadmap. We are not just going to review a list of symptoms here, we are building a precise execution protocol for your clinical reasoning. We're going to filter out the noise and focus purely on the hard diagnostic data. Let's get to it. So, here is the diagnostic matrix we're about to traverse. We've got three distinct modules: humoral disruption, combined and cellular defects, and phagocytic malfunction. And then we're going to lock it all in with a mandatory high-speed validation drill at the end. Module 1, humoral disruption. Think of this as the maturation stage for NINC, where we're looking at a critical first principle concept: B-cell signal transduction failure versus an isotype switch failure. Okay, our very first crucial tool is the signal-to-noise filtering protocol. You know, in clinical immunology, it is incredibly easy to get distracted by what I like to call step 2 noise. I'm talking about recurrent otitis media or general sinopulmonary infections. These are totally nonspecific. They're just noise, and you literally have to discard them from your primary diagnostic thought process. To avoid those classic diagnostic traps, you need to laser focus purely on the hard indicators. Is there an absolute presence or absence of lymphoid tissue, like tonsils? What are the exact quantitative CD19-positive B-cell counts on flow cytometry? That is your true signal. Let's put this into practice on the judge's bench, comparing X-linked agammaglobulinemia, or XLA, against common variable immunodeficiency, CVID, head-to-head. When we break down the molecular defect, in XLA we're dealing with a mutated Bruton tyrosine kinase, or BTK gene. That mutation results in a complete arrest of B-cell maturation. CVID, on the other hand, is a defect in B-cell differentiation and co-stimulation. Because of these distinct mechanisms, flow cytometry tells two entirely different stories. XLA is going to show an absolute absence of CD19-positive B-cells in the peripheral blood, 0. But CVID, it actually shows normal numbers of those CD19-positive B-cells, but they're dysfunctional, which is what leads to those low immunoglobulins. So how does this actually look in practice? The clinical clues for Bruton's XLA are pretty stark. Presentation is almost always in males. You see severe hypogammaglobulinemia, and here is your physical exam clincher: absolutely no palpable lymph nodes and no tonsils. The onset is typically right after 6 months of age, which makes perfect sense because that is precisely when the protective maternal IgG wanes. Now compare that to CVID. CVID presents much later. We're talking the second or third decade of life. Patients will have palpable lymph nodes, and they carry a significantly increased risk of autoimmunity and lymphomas. The absolute crucial point here is this pathology variance box. Anchor this one in your mind, guys. If you see a mutated BTK gene paired with an absolute absence of CD19-positive cells, you are looking at XLA. Boom. That's a high-contrast takeaway you just cannot afford to miss. All right, moving right along to Module 2, combined and cellular defects, otherwise known as the aperiodic lymphocyte list. This is our second biological fork, establishing the framework of thymic epigenetic dysgenesis versus VDJ recombination failure. Think of severe combined immunodeficiency, or SCID, as a relentless, strict chronological cascade. It kicks off at the genetic level, usually a failed IL-2 receptor gamma chain, or an adenosine deaminase deficiency. That genetic failure leads directly to step 2, absolute lymphopenia. We're talking severely depleted CD3, CD19, and CD56 cells. Clinically, this manifests in step 3 as profound failure to thrive and intractable diarrhea, which inevitably ends in step 4, a fatal opportunistic infection within the very first year of life if it's left untreated. Clinically, this presents as that classic devastating triad in an infant: persistent thrush, extensive diaper rash, and failure to thrive. You also need to be looking for the absence of lymph nodes and a hypoplastic thymus. Because of this profound combined T and B cell depletion, SCID isn't just an illness, it's an absolute pediatric emergency. The required treatment matrix involves aggressive antimicrobial treatment, immediate protective isolation, and ultimately a hematopoietic stem cell transplantation. So how do we manage this depletion? It's all about the severity invasiveness scale. Notice how the absolute lymphocyte count aligns directly with your intervention urgency. If counts are normal, say over 1,500, but the patient has issues like recurrent thrush, you might just track quantitative IGs and run prophylactic antibiotics. But as that count drops below 1,500, especially if you start seeing somatic signs like hypocalcemic tetany or an absent thymic shadow. Your urgency escalates to interventions like a thymic transplant. And if that count is critical, meaning under 500, with absent lymphoid tissue, you are instantly in immediate stem cell transplant territory. No waiting around. Now, speaking of that absent thymic shadow, we absolutely have to talk about DiGeorge syndrome. This is beautifully captured by the Catch-22 mnemonic. It stems from a 22q11 microdeletion that basically causes a failure of the third and fourth pharyngeal pouches. C stands for cardiac abnormalities, things like tetralogy of Fallot or truncus arteriosus. A is for abnormal facies, T is for thymic aplasia or hypoplasia, C is for cleft palate, and H is for severe hypocalcemia. And keep in mind that hypocalcemia can present as life-threatening seizures in a newborn. Time to lock this in with another pathology variance box. This cements our absolute diagnostic indicators for cellular defects. If you see an absolute lymphocyte count of less than 500 or an absent thymic shadow on a chest X-ray, you are operating within the SCID or DiGeorge spectrum. Evaluating that thymic shadow and meticulously tracking those lymphocyte counts, totally non-negotiable. Okay, into our final core module. Module 3, phagocytic malfunction. We refer to this as the oxidative burst grid, contrasting superoxide anion generation directly with MAC1/LFA1 integrin expression. Back to the judge's bench, we're drawing a really stark head-to-head comparison here between chronic granulomatous disease, CGD, and leukocyte adhesion deficiency, LAD. In CGD, the underlying pathophysiology is a defective NAPDH oxidase complex. In LAD, it's a defective CD18 integrin subunit. The pathogen vector for CGD primarily involves catalase-positive organisms, but for LAD, you're looking out for non-purulent bacterial skin infections. With CGD, the core issue is that defective NDPH oxidase, which means there's a defective production of reactive oxygen species. Because the patient literally cannot produce their own respiratory burst, they become incredibly susceptible to catalase-positive organisms, bugs that can destroy their own hydrogen peroxide. So keep your eyes peeled for Staphylococcus aureus, Aspergillus, Nocardia, and Serratia. And remember, the diagnostic gold standard here is an abnormal dihydrorhodamine or DHR flow cytometry test. Now contrast that with LAD type 1. Honestly, this presentation is just fascinating. You have impaired chemotaxis because of a CD18 deficiency. The neutrophils simply cannot migrate from the bloodstream into the infected tissue. This creates a massive clinical paradox. You see extreme neutrophilia in the blood, sometimes shooting way above 50,000, but there is an absolute lack of pus at the actual site of infection. It's literally a microscopic traffic jam. The cells are dressed, they're ready for battle, but they're completely locked on the highway. A classic presentation of this is delayed separation of the umbilical cord, lasting beyond 14 days, with onvulitis but zero pearly drainage. Let's deliver your definitive bottom line for phagocytic disorders. In the end, flow cytometry provides the ultimate diagnostic verdict. An abnormal DHR test proves CGD, whereas an absent CD18 marker proves LAD. Memorize these specific markers. They are your signal in the noise. All right, we have covered a massive amount of high-yield data. Now, we're going to escalate the pace. It's time for the mandatory validation drill. I want you to synthesize everything we just talked about and apply it directly from theory to practice. You ready? Vignette 1. You've got an 8-month-old male presenting with recurrent Pseudomonas pneumonia. The physical exam shows an absolute absence of tonsillar tissue. Flow cytometry reveals normal CD3 positive T cell counts, but an absolute count of 0 for CD19 positive cells. Apply your signal-to-noise filtering here. What's the diagnosis? Let's break that down real quick. The timeline fits perfectly, right? Maternal IgG waned around 6 months, leading to a severe infection in a male patient. The physical exam showed no tonsils, but the ultimate signal was the flow cytometry confirming exactly 0 CD19 positive B cells while maintaining normal T cells. The diagnosis is absolutely X-linked agammaglobulinemia, or Bruton's. The definitive next step here is to initiate monthly intravenous immunoglobulin, IVIG, and test for that mutated BTK gene. Let's fire off Vignette 2. A 3-week-old neonate is being evaluated for a persistent, non-healing umbilical stump. You observe significant erythema, but absolutely 0 fluctuance or purulent drainage, no pus at all. A complete blood count reveals an extreme white blood cell count of 48,000 with 85% neutrophils. What is your diagnosis? Here is exactly what's happening. You have that classic, glaring paradox of extreme leukocytosis combined with a total absence of pus. The pathophysiology traces straight back to defective CD18. The neutrophils are stuck in the bloodstream and simply cannot migrate to the tissue, causing that umbilical stump to fail to separate. The diagnosis is leukocyte adhesion deficiency. Your diagnostic loop closes with flow cytometry for CD18, and you must immediately evaluate this patient for a stem cell transplant. To wrap up this explainer, I want to leave you with this thought. When you are navigating the complex, high-stakes matrix of congenital immunodeficiencies, you cannot rely on vague clinical symptoms or step 2 noise. Precise data, hard genetic markers, and targeted flow cytometry aren't just lab tests. They are your ultimate execution protocol. Trust the data, trust the process. Thanks for joining me on this explainer, and keep filtering out that noise.